Okay, good evening, everyone. Welcome. My name is Mohsen Salim. I'm one of the project managers here at SME Symposiums. And today's topic is going to be about an A&E survival guide. So I'm really glad you all are here because this one's a big one. So swiftly going into it. So today's agenda is the timings have got to change. That's my bad. It's from 7, and then we're hopefully going to finish at about 8:30. 9 o'clock UK time. So today our speaker is Dr. Simren Dhaliwal, and she is a graduate from Trachea University, currently working in acute medicine. So me and her were just talking about in terms of all the urgency and the preparation needed to survive in an acute situation in the clinical setting. And that's something we don't get a massive education on. So we thought this webinar would be great to give information out on that. Just before I hand it over, I want to give a big thank you to our sponsors, Lectorio. So Lectorio is an all-in-one study resource for medical students that combines learning science and medical education into one easy-to-use platform. I'm sure you guys have heard me say that every time we have a webinar, but I'm guessing a lot of you guys have exams right now, as do I, and I'm actively using it and I'm loving it, honestly. It has question banks, it has videos, lectures from some of the best doctors around the world. And all in all, it's great. If you do want to sign up to it at the end, when you do fill out the feedback form, you'll get a 50% discount code sent to you that you can use. And we do have some free passes that we will be handing out. If you just put your number into the feedback form, we're going to give the person who gets it a call or a message. Okay, I am going to hand it over to Dr. Simren Dhaliwal. And thank you for hearing me out.
Okay, so my name is Dr. Dhaliwal. I'm one of the doctors that graduated from Trachea Uni, and I work in acute medicine. So we work really closely working in A&E. So I'm going to give you a little guide of what it's like to be an on-call doctor, what it's like to go in acute medicine, and what it's like to be dealing in A&E, and like all the little cheat sheets almost that you guys will find useful during your time. So we're going to go over. We're going to go over what happens in A&E, what is acute medicine, because I didn't know what this specialty was when I started, working under pressure and like little tips you can do, things that you should know when dealing with an on-call shift, be it day or night, the discussion of respect, so previously known as DNR. That's something that we're not heavily taught about studying abroad, but in the UK it's heavily emphasized, and especially with the pandemic, it's something that they talk about a lot. Dealing with difficult patients, and there's a little case study at the end, and then if you guys have any questions. So basically what happens in A&E is people are brought to you via 3 different routes. So they can come via self-referral, so they'll come in, check themselves into A&E, and they'll be put onto the waiting list. They can be a GP referral, in which the GP has told us that, you know, they ring in advance, they tell us that a patient's coming, and we already are prepared for them. Or BIBA, which stands for brought in by ambulance, and that's obviously an emergency situation. So A&E tends to be divided into different sections. You have a majors, minor, and ambu. So majors will be things like somebody's got really severe exacerbation of COPD and they need full escalation of treatment. Ambu is someone like a stroke or someone who needs intensive treatment while we're trying to figure out where they go in the rest of the hospital. And then you have minors, which is people that have come in with like cuts and stuff. They just need a quick check. They've got mild vomiting. It's not that serious. And so you should always remember your A's to E's, which is breathing, airways, and circulation. Just get rid of that up the way. Oh God, I don't know how to get rid. But anyways, and you should always remember airway, circulation, breathing, go through all the steps. It's best to know them when you come in because they use it for everything in A&E. And even as you progress throughout the hospital, the doctor that you're going to be referring to is going to want to know the A to E. Always remember to take a full medical history. So when you introduce yourself to the patient, you'll have a list. So depending on where you are in A&E will be dependent on where you go. So the list will come up and you'll take your patient, you'll call for the patient's name, you'll bring them into either a room, or you'll already be going to the room that they're in. You'll check their name and their date of birth. This is always needed to be done so that you know you're talking to the right patient. And you need to just make sure you have all the right documentation. You want to know why they're here. What was the present complaint that brought them to the hospital? And then you start being a detective and working out, okay, do they have anything else that could have caused it? So like, for example, if they're saying they've got chest pain, do they have a history of angina? If they're saying that, you know, their feet are feeling really tingly and they've had loss of sensation, are they diabetic? So you want to slowly go through the diagnosis and like go through their past medical history, because that's going to help you come to your conclusion. Always remember family history, because that's a big thing, and it's not, you don't always think about it when you're in that situation. Social history is super important. You want to know, does this person live with family? If they're old, do they live in a house or a bungalow? Do they already have a package of care in place? Package of care is, does this patient have carers that come in to see them, help them do their daily activities such as washing themselves, dressing themselves? All these are really important information. You want to ask about whether they smoke, whether they drink, what their occupation is, because all of this will help with your diagnosis. And pets is a big thing, because believe it or not, having birds is actually one of the common reasons for having a particular type of pneumonia. So if you instantly figure out if they've been in contact with any birds, that will really help you. And of course, drug history. So you're already going to have access to the NHS system, which is called the NHS Spine. So you'll use your NHS card to log into this. But surprisingly enough, the drug history isn't always on there, and it's not always correct. So we'll go through this all, and then document everything you've done. It might seem minute, it might seem silly to you, but you will document everything, because it's not just for you to state what's happened throughout the patient's entry into hospital, it's also covering yourself, so that if something's happened, you can be like, okay, no, this, I did do this and this has happened. So for example, if a patient states to you, oh, you know, I don't smoke, blah, 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 but it turns out that, you know, they've got a severe type of COPD, you can document that on your side. Okay, well, I asked the patient, they didn't say they smoked, just so that it doesn't look that you did poor performance on your side. So who is your team in A&E? So obviously you have your doctors, you have your registrars, your consultants. You always have an A&E consultant present at all times. In other departments, that's not necessary, but in A&E, there's always a consultant. You obviously have your regs, you have your clinical fellows, which are like FY3s that may be doing research or something. You have your FY2s, and then you have yourselves. And then you have these things called PAs, which are physicians associates. And so they are above nurses in the sense that they're able to take bloods, like nurses are, but not all nurses are actually qualified to do that in England. But they can also do all the practical 15 core procedures that you as an FY1 doctor should be able to do, or FY2, but they can't prescribe. So they're really useful in A&E because they can do maneuvers and stuff, taps, all that sort of thing. So they're really helpful to the doctors themselves. Then you have your matrons, and they make sure that the ship is running smoothly. So they make sure that the patients who are coming in are seen to, and that there's nobody staying over. You'll hear this term breach used a lot when you're in A&E. Breach stands for you have given a time slot. So each patient is given an allocated time slot of how long they're allowed to stay in A&E. So each trust is different. Most trusts, it tends to be about 4 hours long. And what that means is that no patient should be in A&E longer than this 4-hour breaching period, because what that means is that there's another patient in the waiting room or coming by ambulance that's not going to get a bed to see to, because we haven't treated the patient who's already with us right now. And so the matrons make sure that that's all running smoothly, and they're the head of all the nurses. Then you have nurses, CSAs. CSAs and phlebotomists are the same thing. They're just different terms in different trusts. And they're really great. I mean, they can cannulate the most difficult of people. They can take bloods from really hard people to bleed, which you'll find in A&E, like drug overdose users sometimes can be really difficult to bleed. And HCAs are your people who help with everyday activities for the patient. So common things you're going to see in A&E, you're going to see overdoses. Overdoses are such a big thing, and paracetamol, believe it or not, is your biggest overdose. Paracetamol, ibuprofen. Some people overdose on their metformin, for example, which can lead to metformin-induced cardiac arrests in some cases, which is very severe. Recently, we had a patient who came in, overtook on a couple of metformins, which led them to have a really high rise in their troponin levels, but they didn't actually present any MI symptoms, which was crazy. So just be considerate, think of things like that. I'd say a good resource to use is, while you guys are studying now, is those questions in internal that are like about intoxications and overdoses, that probably focus on them, and use a really good website called Talkspace to help you figure out how to treat these overdose patients. So most patients that come in with overdoses, you want to think about food resuscitation, monitoring them. Aggressive behavior can be one, but it can affect the pH of their blood, it can affect the pH of their urine, it can affect their potassium levels. So you need to be able to think about all these things. So electrolytes is another big one. Alcohol intoxication, so you want to remember your Pabrinex, which is your vitamins, combination of vitamin C and your vitamin B12s and all of them. You want to think about, some patients are going to want to come to you and be like, I want help, and they want to be coming off of the alcohol and want to detox. So you have to then think, okay, when someone's going through the detox regime, they're going to be slightly aggressive, agitated. So you just want to prepare yourself for those situations. Falls is a big one amongst the elderly. Patients will come to you with a fall. They might not remember if they banged their heads. Straight away, you book a CT of the head, because you want to rule any intracranial bleeding. You want to take an X-ray of any imaging, any areas that they say they've hurt. Their wrist is a common one. Shoulders is a common thing. Hips, knees, all of these things. So make sure you opt to scratches with like your movements, your ranges of motion, knowing how to examine a knee, a hip, and the knees and like the wrists, and knowing how to examine them all as individuals. Because when your consultant comes around, he's going to ask you, okay, were you able to perform the knee examination? And so you need to be able to compare the lefts to the right, because depending on where they've fallen down. Sometimes it's very difficult to take a history from these patients. So you want to then think about taking a collateral history, which means taking a history from a family member or a friend or a carer that they have. Fractures is another big one. PR bleeds. This is when you've got to think of, when a patient is saying to you that they've had a PR bleeding, which is perirectal bleeding, you need to do a PR exam, because you need to exclude any hemorrhaging, anything that could be in that area. It could be an enlarged prostate. You need to be able to examine that, because that's important later down in the line. So whatever you guys do in A&E will set that patient up for the rest of their hospital stay, because when that person gets moved about from A&E to another ward, to acute, to rest, or wherever, they're going to base off, okay, what did A&E find? What did A&E do? And they're going to concentrate majority of the time on that, and then they're going to move around, perhaps around the patient as well. So you need to really focus on why the patient's here, but also look around. Chest pain is a really big one. Sometimes patients don't always have chest pain because of an MI. They might have chest pain because they've got a bit of gastric burning. They might just have they've eaten a bit too much, and now they just need a bit of Gaviscon, but they've mistaken it as being some pain that we associate with something more sinister. So you need to think of all your differentials. And sometimes chest pain can be due to angina. It could just be an angina attack. But whatever it is, you need to straight away, chest pain, ECG and troponin levels, your best friends, always go for that. Shortness of breath. Sometimes patients will be like, oh, doctor, I came in and, I was going up the stairs and I started to feel short of breath. Always ask patients that come to you that are asthmatic, that have COPD, always ask them, okay, how far can you walk before you feel short of breath? Because that will show you, is this shortness of breath a new thing? Or is this shortness of breath something more progressive, or has it always been there and it's not something you perhaps need to focus on, that's the actual reason that they've come in? And infections, so your COVIDs, your pneumonias, your exacerbation of COPDs, your all sorts. Remember your cellulitis, guys, that's a big one as well, especially amongst the diabetic community. A lot of people come in with diabetes related infections, so always think of that, because majority of the time you're going to see someone's going to need an amputation at some point. And when that happens, you want to remember to check all your pulses. So this is when you need to check the pulses in the foot, the pulses in the knee, the pulses in the femoral, just to see, is there still blood supply, or is this foot towards the end? Okay, so acute medicine. So acute medicine has been a very relatively new specialty, in the sense that it wasn't fully developed for many years. So acute medicine is basically when patients come in from A&E, before they're distributed to different parts of the hospital, the acute medicine department will decide, do they actually need to be in hospital? Do we need to admit them? Or can we fix them within the next couple of days, patch them up and send them back home? Just because you have to think about hospital spaces. So in acute medicine, it's all about clerking a patient. You as the acute medicine doctor will go in, you'll go see the patient, you'll go through all the NHS records, you'll redo basically whatever A&E did again, and then you'll make a treatment plan. So if somebody's come to you, they're really confused all of a sudden, they've got really dark urine, pain on urination, you're going to think, okay, is this delirium secondary cause due to a UTI, which is a urinary tract infection? So you want to do urine culture, blood samples, check if they're spiking a temperature. You want to do a full blood count. You want to then think about, okay, what type of antibiotics should I be prescribing for this patient? But they might be like, oh, it might not be due to a UTI, for example. So then you need to rule out what else could it be? Do they already have dementia that's just progressed a bit more? Or did they have a fall or something? So you've got to kind of, you get more chance to be in depth rather than comparison to A&E, where it's very, very quick. Always remember drug history. So drug history is something that tends to catch a lot of people out in the sense that you think that everything's on the NHS record and it's not. What happens is a patient will come in and they'll be like, oh, my GP doesn't know I don't take this anymore. Or, oh, you know, I went to see somebody else and they said I could have this medication. And the GP won't know everything. So sometimes you need to double check with the patient as well about what medication they're taking, because it won't always be on the GP records. Warfarin is a big medication that it will literally just come up that the patient is on warfarin. You don't know what dosage they're on. You don't know what their target INR is. You need to ask the patient. The patient knows best in this situation, because every week warfarin is dosed. Every week that patient will go into their GP practice. They will have a blood test done. The nurse will then recalculate his warfarin dose, and then his new set of pills will be given to him. So for example, a patient might have 4 milligrams on Tuesday, 4 milligrams on Wednesday, 5 milligrams on Thursday, and then Friday they don't have anything. So it's just every patient is very specific, and you need to make sure that you don't give too little or too much in that situation, because patients that have warfarin tend to have an underlying cause of AF, which is atrial fibrillation, and we don't want them to get a clot. You don't want to put them at risk to that, because patients coming into hospital think that they're in the safest place at that point, so you don't want to cause any harm. Parkinson's medication is another big one. Each patient has its own Parkinson's regime, and each patient's carer will know that regime off by heart in most cases. So always ask the patient's carer if you can't somehow access to the patient or they're unable to communicate with you, because it's always taking at a set time between a set period in between, and some patients will have Gaviscon before or afterwards. So you just want to double check. Insulin is another one. Insulin, every patient has a different dose of insulin, which I'm sure you guys will already be aware of, but some patients might take 24 units in the morning and like 6 units at night, or the other way around, or one patient might take more amount of insulin than the other. So you want to make sure you ask the patient what units they have and what's their targets, BMs, blood glucose levels. So they'll know that, and then you'll be able to accordingly decide, okay, is this patient well controlled, or do we need some diabetic nurse help? Most like specialities will have subspecialist nurses, and they are always on the go and they're lovely. So stroke nurses will be your best friends when you're in A&E, diabetic nurses when you're in acute medicine, cardiac failure nurses, they'll come around into A&E, and these people will be able to help you when you're just starting off. They're easily approachable as well, and so just go up to them and ask them a question if you're not sure, because they will know medication regarding that specific area that they're working in. And then if you can't seem to get anything from your patient because they're too delirious or they're they're not conscious, then you always take a collateral from the patient. Never write off your patient and be like, oh, well, I couldn't take the history from the patient because patient was not communicating, or patient was uncooperative. Because at the end of the day, you've taken that patient and that's your responsibility. So whether you go and find someone else to, try and communicate with the patient because the patient's being difficult and doesn't want to be treated by you, it's your responsibility to then find someone else to treat the patient. Or if the patient's just completely not communicating, then it's your responsibility to contact a family member, a carer, to get a collateral history to figure out what brought the patient here. So on calls, that is what your bleep will look like. It is the most loudest thing you'll hear in some situations when you think everything is calm, but it can be hard and it can be intense. But on-calls don't have to seem scary at all. They're actually pretty chilled sometimes, but sometimes it can be sometimes they're a really big learning point for yourself as well, because working under pressure, you realize how much you actually know and how much you can do. So whilst you're carrying the on-call bleep, you'll also be doing your work. So if you're working in acute medicine, you'll be clerking patients from A&E, and then you'll carry this on-call bleep. So you'll be bleeped about stroke alert. So if a patient is coming in with a stroke, it's a stroke pre-alert. So the ambulance will alert the hospital beforehand. And so acute medical doctors need to be on standby, A&E doctors will need to be present, and a stroke team will be there. And you guys will be bleeped beforehand to let you know. So you'll go there, you'll have the team there, you'll have a discussion. Somebody will think just before the patient's coming in as to how we're going to tackle this, because the ambulance would have given you a quick brief. You might get bleeped for a cardiac arrest. In that situation, it will be you and the critical care team. So just always remember, in most situations, in terms of A&E and acute medical point of view, you will be bleeped with other members. It won't just be you. But being on call, just work efficiently, don't stress. It's not about working quickly, it's about working effectively and knowing when to escalate your problem. Just because you've been bleeped for something doesn't mean you have to be the person to fix it. Some things are going to be out of your depth. And obviously nurses have a point of escalation. You're their point of escalation. You then have someone else to escalate to. So you should never put yourself in a situation where you're out of your depth, because that ultimately causes harm to the patient. Oh, and just going back to that, there are points that you need to remember for handover. So handover is something that happens in between the morning and the night shift. So if you're the night shift team, you have to then report everything to the morning team as to what's happened. And the night shift team has to be slightly more in detail because you don't have as many seniors around. So the senior teams are going to come in the morning. They're going to be there to troubleshoot any issues that you guys have had. So you need to make sure you give them the important points, like if there's anything in the blood works that needs to be alerted about, like a high white blood cell count, a high CRP, you need to make sure you're telling them if someone's got high BMs, if you suspect someone might be deteriorating. So always remember, when you briefly hand over a patient, always put what the patient's come in with, what their medical background is, what you've done, what the work showed. That is a quick snapshot because you've told them why they're here. We know a bit about their background. We know what we've done with them. And then that kind of gives the next working doctor a figure to be able to figure out what to do next. So common things you guys can get bleeped about on other parts of the hospital, not when you're just on the acute floor. So even in acute medicine, you guys will get bleeped about patients around the hospital as well in some hospitals, depending on what type of hospital you work in. So a patient musing really high. So I'm sure you guys might not be familiar with this, or you will be, but muse is basically based on a patient's respiratory rate, their saturation rate, their blood pressure rate, their pulse rate, and their temperature, and if they're alert verbally, if they're communicating with you. And that is for the nurses to then decide, well, not decide, that's the way in which a nurse can then escalate to you if a patient is musing really high. And there are different points in which a patient can muse high. It won't always be in the same thing. So a patient might muse really high due to having a really high blood pressure or a really high pulse rate or really low saturations. So always when you get bleeped about musing patients, always ask, where is the patient musing really high? Because that will tell you, okay, if someone's saying to you that they're high because of their blood pressure while you're on the route, you can be like, okay, what is the reason why? If they say to you they have high blood pressure, always ask, what was the previous blood pressure? Because it could be something that's not new, that's something this patient's always had, but nurses are just following their protocol and you have to follow yours. And so you still have to go see the patient and assess them. Stroke alert, like I already said to you guys, sometimes they'll be pre-alerted. Sorry about the little mishap there. But always think about facial drooping, weakness of the limbs, possible risk factors. Are they, atrial fibrillation? Are they on any medication? How severe is it? Things like that. Sometimes pre-stroke alerts can be, patient might not even be having a stroke. It could be a residue from a previous stroke. So you need to think about those as well. So the CT head always is your first point, and it will be able to show you if there is a new stroke or not. Cardiac arrest, like I mentioned, the critical care team. So the critical care team are basically a team of people who are experts in cardiac arrests, and they tend to be there on the site straight away when it happens with you doctors. And it consists of having a nurse. Most cardiac arrest teams also have an ITU doctor present as well. Just in case if the patient deteriorates too much, they need to be taken up to ITU. The ITU doctors have seen the process and they're ready to take up. Patients taken to ITU don't always just have to be going through a cardiac arrest. You could have a patient who's got really low blood pressure or really low pulse rates, really high blood pressure, really tachy, like it's just a variety. Patients having hematuria, this is blood in their urine. So sometimes you can get bleeped for this, and you just need to think to yourself, okay, what could be the cause? So in patients who have dementia, it could be due to them not understanding what this catheter bag is and they're trying to pull it out. So that trauma can cause them to have hematuria. They could be having an underlying cause like bladder cancer or something. So when a patient has hematuria, you want to request for a change in their catheter bag. And then you want to stop any anticoagulant medications that they're on for that night. And you want to monitor the urine output, and you want to monitor the catheter bag until the hematuria stops. In some cases, patients might have blood clots, and this can be really bad for the patient because it can stop the urine from draining. And in that situation, you need to place a three-way catheter. So a three-way catheter tends to be slightly larger than a normal catheter, and its point is it has three things in it. So a normal catheter will have a draining bag and then a balloon slot that will blow up. The third slot will be for you to do irrigation. And so what that will do is that's literally washing out the whole bladder and pushing out any clots that could be blocking any urine or any hematuria that could be present. It just drains it out and flushes it out. And you continue this irrigation until the hematuria stops. So three-way catheters, think about if the patient's got blood clots or the urine's not coming out, that's when you want to use a three-way catheter, and always think irrigation. Nurses carry out irrigation. They know how to do the irrigation. So always take a nurse with you when you're doing the irrigation because they know that's their step. But also remember, they're going to ask you, when do you want to stop the irrigation? You're going to say when the hematuria stops. Patients having a fall. Sometimes you'll be on a shift and a patient will have a fall in the ward, and you will get bleeped. Neuro-obs every 15 minutes, and then it's every hour, and then every 4 hours, and always do a CT head. Most of the time, these tend to be unwitnessed falls because a HCA is busy with someone else or a nurse isn't present or something. You might have a patient who rolls out of bed. Think about it. They're not going. Some of these patients might have dementia. Some of these patients might, have injuries to their limbs, so they're unable to move about. So you always want to go in for a head CT. Ask the patient what happened, check their neurological observations, check the part of the body that's been injured, for example, as well, and then always monitor them. And handling aggressive patients. So you will come across quite a couple of these situations. Sometimes you have to remember it's not the patient themselves. It could be the disease that they have. It could be a consequence of medication. It could be a consequence of withdrawal from alcohol or drugs. Regardless of the situation, you need to figure out how to handle these. So when a patient is being aggressive towards the nurse is going to escalate to you. So what you then need to do is decide if this patient has capacity, why they're being aggressive, try and work in an understanding with them. But always remember your safety is important. So if the patient is being aggressive towards you, you step back and you call for help and you escalate, and you always have your security team on hand that will come up if needed. Security won't touch the patient unless they have a mental capacity sticker on, which we're going to talk about in a second. So let's go back to working under pressure. Just remember to stay calm at all times. When you get bleeped about any of these patient situations that we've just spoken about, you want to go through the history because you're not going to know the patient. You've just been bleeped about them. So you want to go through, why did the patient come here at the beginning? What is the past medical history? What drugs is the patient on? You need to show that you've checked the drugs. So in most trusts in England, they use this thing called EPMA. So when you're writing your little entry in the book, you're going to be bleeped, on-call bleeped doctor, whatever, whatever level you're holding the bleep at. And you're going to be like bleeped for hematuria or bleeped for patient falling or something. And then you're going to write, okay, you're going to look at the patient through the book, why they came. You're then going to read through their past medical history. You're then going to check their bloods, recent bloods, and maybe a day or two previously, depending on how long they've come in. Then you're going to write bloods checked, EPMA checked. EPMA is their drug history, their drug chart. You want to check that. Sometimes some trusts will do it on a paper format. You check the paper format just to make sure, is there any drug that could have caused this, or is there any interaction that you should be worried about? You write that down that you've checked it. Any recent imaging the patient's had, so CT scans, X-rays, MRIs, any of that thing, you check that and then you note it down. This is all to show that you have gone in a logical point, but it also helps you to figure out why you were bleeped, and also to help you figure out what your next point of plan is. Then you're going to write, you're going to go and see the patient. You're going to write down the observations, write down how the patient is. Are they sat down? Are they unconscious? Are they lying down? How are they? Write that down. You write the observations. You write down the respiratory rate, the blood pressure, the heart rate. You write all that down from the new scoring chart, which will be at the end of the bedside table. And then you then look at what the previous team have done. So what is the current team that's looking after the patient? What have their management plans been? What have they decided? You know, is there something that they don't want you to do? Is there something that they're avoiding for a reason? You check for that. And then lastly, you always ask the nurse looking after the patient, because there's always going to be one nurse in charge of each bay. And so she's going to know her patients very well. So you want to ask her, is this patient not in their baseline? Has this patient changed recently? How was the patient before you bleeped me? Anything like that. And baseline is the buzzword for this slide. So baseline is basically a term that is used in the NHS a lot. And that is, what is the patient's normal state? So for example, a patient who is fit and active, that's their normal baseline. They're able to perform their own daily activities and able to walk. And you want to know that when they're in A&E, what their baseline is, so that if in their hospital stay they deteriorate or anything happens to them, we know that that's not their normal baseline. And you want to always bring a patient back to their normal baseline before you discharge them home, because you don't want to discharge someone home who's below their baseline. We've essentially then, in most people's eyes, have made them worse. So you always want to bring a patient back up to their baseline. So baseline is knowing if a patient can perform their daily activities, knowing what they can and can't do. Are they able to walk around? Are they able to brush their hair? Are they able to brush their teeth? And there's things like that. So, and this is what it looks like in a clerking book. So you always remember the AMTS score, which is basically a mental capacity. Well, no, it's basically a mental assessment. So you want to see, do they remember their age, their name, their date of birth, the current location, historical date. I always tend to go for World War II. Most geriatric patients will know that day. If a patient doesn't know the World War II date, then you can think of something a bit more recent. 2 people, so you want to introduce yourself, perhaps the nurse maybe. Recalling an address, so can they recall their own address, or maybe you give them an address at the beginning of the consultation and see if they remember it. A monarch, so do they know the Queen's name? Ask them to count back from 20 and always ask them what the current year is, and you score out of 10. And you do that at the beginning when you clerk a patient in, so that we know their baseline, so that we know that if they've deteriorated throughout and they can't do this, when we recheck this AMTS score, we know that, okay, the patient's deteriorated, or okay, the patient's improved. You also have the Rockwood Frailty scale, and this again is about baseline. So can the patient, is they normally fit and active? Are they running about? Are they okay and active, but they do have diseases, but they're not limiting their daily life? And it just go on throughout. So right to the end, where they're terminally ill, they're dependent on somebody. Always think about patient's baseline. That will always help you. So to resuscitate or not to resuscitate, that is the ultimate question. This is quite a big topic recently. It's become quite hot within the NHS, and it started to become really important from 2020, around about in March, April, May time, I want to say, where this thing called Respect Form came out. This is all about, do you resuscitate? Do you not resuscitate? Which patients are okay to resuscitate? Which patients aren't? And this is really important. It didn't come out because of COVID. It coincidentally happened during COVID, but they had been planning it for months. So you want to be able to bring it up to the patient. So you always want to think about, okay, you want to be sensitive, you want to be polite, you don't want to be rude. patients will be scared when you bring up resuscitation, no matter, because they might have just come in with some cellulitis and now you're talking about their heart not working. You're going to make them panic. So you need to be nice about how you talk about this situation. You need to make sure that they understand that in a situation, if you're not going to resuscitate them, it doesn't mean that we're not going to provide treatment for them. We will treat them up until this point happens, and then we're going to make them comfortable. It doesn't mean that we're going to send them home and we're not going to do anything, which most patients misinterpret as do not resuscitate as, oh my God, you're not going to help me. I'm not going to survive if anything happens to me in hospital. That's not true. It's a medical-based decision in terms of we're weighing out the risks, weigh out the benefits in most cases, because performing, resuscitation isn't something that's it's not very glamorous, let's put it that way. I mean, you're going to put a lot of pressure on the patient's body. They're going to go through a lot. They're going to withstand a lot of things going on. You want to make sure the patient can handle it and that it's in the patient's best interest. But also, you have to make sure that they're aware that how they are now isn't always necessarily how they're going to come back, because there's no guarantee with resuscitation. So you need to make them aware that most patients will misinterpret it as it's their decision. In actual fact, it's not. It's a medical decision which we make together with the patient. So you want to bring up the discussion after. I tend to do it after I've taken the history, after I've chatted to the patient, I've figured out their social history. Some patients will already say to you, I don't want to, or I do want to be resuscitated. And then you have to take that into account, the decision. Sometimes they'll want to discuss with a loved one. You are more than welcome to give them that time, but make sure you go back, because this is an important decision, because anything can happen in hospital to them. The critical care team will want to know, is this person for or not for? Do we need to call the crash team or do we not need to call the crash team? Sometimes patients are delirious and you're going to be like, how am I supposed to have this discussion? Next of kin. You then ring up their family member or their carer or something and ask them. So you always want to bring it up as I have to have this conversation with you. It doesn't mean no chance that, if this is going to happen to you in hospital, but in the unlikely event this does happen, and then you bring it up. And you want to make it as basic and in layman's terms as possible. So if something was to happen and your heart was to stop working, how do you feel about, us performing resuscitation? Some patients might be like, what is resuscitation? Then you need to basically break it down, make sure that they understand what it is. Most of the time, patients are compliant and they're willing to have this discussion. Sometimes patients don't even want to talk about it. It might cause them to cry, break down. You just need to be respectful. You need to make sure that you are understanding of the situation. You give them some time. Sometimes they don't want to talk about it, and that's fine. Sometimes some patients already have a respect form or a resuscitation form already filled out, and they'll come with that. So then you can then use that to look at. So what do we look at when resuscitating a patient? We look at how many comorbidities they have: diabetes, heart failure, do they have arthritis? All these are factors that help make your decision. Do they have cancer? Are they on active treatment or are they on palliative treatment? You want to think about all these different things. And then if the decision is made not to resuscitate a patient, you still have to then let the family know. If the patient is slightly old or slightly more fragile, you then have to let the patient's family know, or the next of kin, that during their hospital stay, if anything was to happen, this is the decision that has been made. And that's what a respect form looks like. So you're going to put in at the top, so in point 2 where it says shared understandings, this bit here, so you write some summary, so like, do they have diabetes, heart failure, hypothyroidism, whatever. Then down here, you're going to put for resuscitation or not, for ward-based care, for NIV. NIV is basically a type of breathing system that you can use. So if a patient is in a certain type of respiratory failure, we might use it. Is the patient for ITU or not for ITU? And if the patient's not for any of these things, then you just put ward-based ceiling of care, which means that we'll look after them in the ward when this point comes, and we just make them comfortable as possible. And then always remember to sign it. So you put what your grade is, your name, your GMC number, which is really important, your signature, your date of time of when you've had this conversation. And if the patient's got capacity, you tick this box here to say that they do, and that they understand what's going on. And if you've had this discussion with someone else, then you also mark that down as to who you had the discussion with. Because Some patients, for example, that have dementia, they'll come in and their daughter will be their main carer. So then their daughter has an input in this decision. So then you'll state that, like, you know, daughter, her name, she had input, whatever. So dealing with difficult patients. So this comes down to when you buzz and when you're bleeped about a patient being aggressive, or when you're in A&E and someone's being rude or aggressive towards you. So you have to remember you're there to try and help them. Sometimes they can be really rude and aggressive towards you. It's not they're being aggressive towards you as a person. It could be their illness, their disease, like I said previously. Sometimes you can get really difficult patients, and you have every right in that situation not to treat them if you're putting yourself at harm or they're putting your staff at harm. So, but like the same situation as previously, when a patient's not engaging with you, you then need to find someone else who can treat them if they don't want to be treated by you, because that's still your responsibility. So I'll give you a scenario, and it happened recently in my hospital where a patient came in. They were really aggressive because they had HHS, hyperosmolarity, and basically due to having diabetes, that wasn't well controlled, and they were just really rude and aggressive to one particular doctor. And they wouldn't let this doctor put in a cannula, so they couldn't get any fluids through them. He wouldn't want to drink the fluids that they were giving him. He was trying to light a cigarette inside, which is dangerous because we have oxygen tanks. And what the doctor failed to do in that situation is they didn't then escalate and get another doctor to come and treat this patient. They kind of just left them. This patient got moved over to my ward, and this was the acute unit, because the patient was about to breach because he'd been there for more than 4 hours. And the consultant on our ward was a bit disappointed because she was like, if this patient has HHS, why is there no cannula? Why has this patient not had fluids? And so what happened was, because that doctor failed to escalate or failed to get another person to come and try and put a cannula in, this patient didn't get fluids for over like 10 or something else, because when the patient was brought over to us, they weren't straight away seen by a consultant or by a doctor straight away. Like the doctor presumed there was a cannula or there was some form of miscommunication. And so what happened is this patient was without fluids for a while, which obviously caused them to deteriorate more, which led them to going into ITU. So always remember, if you're in a situation like that, you tell someone else, you escalate, because you still owe this patient treatment because they're your patient, if that makes sense, until you've handed over, or until somebody else has said, okay, we'll escalate, we'll take over. So what you're going to do with a difficult patient is you're going to try and ask them, to be respectful, explain to them what's going on. If they're still not interested, if you know it's not them being difficult due to their own behavior, then this thing called mental capacity comes into stage. So there are loads of different reasons why a patient could be difficult. They're not complying with the treatment that you want to give them. They're not answering the questions. They don't want to go through diagnostic imaging, and they might have their own reasons, or it could just be because they are intoxicated or because of the medications we're giving them or something. If it's because, or it could be because they have dementia, for example. And so then this thing comes of, does a patient have mental capacity or not? Having mental capacity means you have the right to make your own decisions. You fully understand what we're saying to you. You're able to recall this back to me so that I know you understand what I'm saying to you. And so mental capacity can be permanent. Mental capacity can be fluctuating. And so you need to figure out, is your patient being difficult because they're always like that? Is this patient being difficult with you because they've got fluctuating capacity? Or is this patient being difficult because of something else? So this is what the mental capacity stickers look like. Sorry, it's not a very good image, but so you want to see, is the patient being difficult with you because, you'll write down in here what the reason is. So patient being rude, patient being aggressive, whatever. And then you're going to tick, does this patient have capacity? So do they understand what you're doing? Yes or no? If yes, then state why. Is this temporary? So are they not normally like this? We're just contemplating, they're just like this because of a specific reason. Are they always like this? This is a permanent thing. Or is it fluctuating? Is it coming and going? Are they sometimes having to have mental capacity? Are they sometimes not able to have mental capacity? So you want to look at things like that. And then you want to write that down. Now, nurses can do this as well as doctors, but sometimes nurses will bleep you, or you'll be in a situation where you'll be called to this because nurse isn't sure herself if this person has capacity. And it's important to figure out, because if you state that a patient doesn't have capacity, this is when you are allowed to get help to calm this patient down, because a patient being difficult can affect not just yourself, not just the staff that you're working with, but also other patients. And in some situations, that can set off or trigger other patients, especially if you're working with dementia patients or intoxicated patients. And when patients are being difficult, they have every right, if they don't want treatment from you, and they do have capacity, to not have treatment. And so in some situations, a patient might say to you, oh, and this happens a lot in A&E or in acute, they'll come to you because there's something wrong, they've presented to A&E, but they don't actually want treatment from you. And that's well within their rights. They could want to go home, there could be something wrong, might not be happy being in hospital, whatever their decision is or the reason, you have to respect that. So then you do this thing called self-discharge. So self-discharge is when the patient wants to leave against medical advice. They want to leave against medical wishes, and they're allowed to do that. But what you do in that situation is you safety net. Now, safety net's a big important thing in the NHS. You state to the patient, you're going against medical advice, you document that down, you write that down, you write down that the patient wants to leave. You then state to them that this is why they shouldn't go. However, if their symptoms are to get worse, or whatever XYZ medication that they need, they are welcome, they should contact their GP, or they should come to the A&E, or they should go and ring 111. That's you safety netting, because you stated that if something bad does happen, you've gone against medical advice, but this is what you can do. Sometimes you'll get patients who are agitated and angry because they're frustrated in being in hospital, and they just want to go out for some fresh air. And then you still have to think about, does the patient have capacity or not? Because you can't send out a patient who has seizures frequently outside alone. So then you'll need to send someone with them. And a patient can be difficult for that reason as well. So you just have to think about all different points and what can make a patient be agitated with you or be angry, not with you necessarily, but the situation that they're in. Because sometimes patients will describe being in hospital as something that they didn't want and they feel trapped, and you just have to understand that. And patients are going through something sometimes in that situation. Most of the time, patients are lovely, they're very well compliant, and they're more than happy to engage with you and make sure that they can help you as much as they can. But you have to just be wary of those patients and never go in alone if you don't feel that you're safe or you don't think that it's appropriate. You should always have someone with you in those situations. And again, if you don't want to treat a certain patient for whatever reason, make sure you always refer and escalate to someone above you, and then hand over and let someone else know X, Y, and Z reason. Because you might get a racist patient, for example, and then you have to be able to deal with that. Sometimes patients aren't racist on purpose, it's just a situation, but regardless of the situation, you should still escalate it, because that's important. So, a case study to end it all. So, I had a patient recently who was a 60-year-old male. He came in, known alcoholic, was brought into A&E with the reduced GCS, which is the Glasgow Coma Scale, of about 9. So Glasgow Coma Scale is scored out of 15. His neighbours rang in 999 because they had some really loud banging noises, hadn't had the neighbour come out of his house, so they were concerned. 999, that then called the police. Police turned up, realised it wasn't a situation for them to handle, so they called the ambulance. Ambulance picked up the patient. He had a really high temperature. They discovered that he recently had a pacemaker fitted in a couple of years ago because he had a pacemaker card. They will have a card in their wallet if they have a pacemaker in them, which will tell you the year that they had the pacemaker done, which doctor performed it, what hospital they had that pacemaker fitted in, and what model, because there are different types of pacemakers which you should be aware of. He came in and was unable to give us a history because obviously he had a very low Glasgow Coma Scale. So we then rang the daughter for Collateral History, who confirmed he was a known alcoholic, and he's had some troubles for whatever reasons. But she wasn't able to tell us exactly what happened, but all she could say was she saw him about a week ago, and he was drinking quite heavily, and he wasn't eating that much, but she tried to drop off some food. When we then discussed, in terms of treatment, this is what we wanted to do, and we discussed the respect form with her, so resuscitation, because of his multiple comorbidities and because of his current state, it wasn't advised for him to have CPR performed. the daughter didn't agree and the daughter wanted full escalation. Because obviously the patient himself was not with us, as in the sense of wasn't conscious, he wasn't able to give his input. So we had to then take into account what the daughter had said to us. And because the patient was relatively young, I mean, being 60 years old, the term for whether we wanted to resuscitate or not was kind of kept in the air, because this was a thing that us as doctors were not sure about. But then the patient woke up and said that, get off of me, I don't want to be treated. I don't want to have any treatment. I don't want to be resuscitated. Let me go. What do you think you should do in that situation? I don't know how you guys can, like, if anyone has any input, and then I can tell you guys what happened.
Guys, if you want to unmute yourself, just feel free to raise your hand and I will let you talk. Do we have any volunteers? Guessing you're on your own, doctor.
I don't think I would have volunteered myself if I was watching, to be fair. So what we did in that situation is, it was then, so then what happened was a couple of doctors' input was taken, and everyone was like, the patient has capacity, we should listen to what the patient's saying, because he doesn't want to be treated, we can't force him, because he was scoring 10 out of 10 on the AMTS score, which is when we talked to them, we asked them about, you know, where they are, who they recognize, what year they're in. That school that we previously talked about in the previous slides, we performed this test with him and he was 10 out of 10. So despite the fact that he was GCS of 9 when he came in, he was recovering and he was scoring 10 out of 10. So that was giving us no reason to say that he wasn't with it. He wasn't able to understand what was going on. However, from that point, at about 10 o'clock, when we were like, yes, we're gonna, you know, we're not gonna treat him. We can't go against the patient's wishes. That's what the patient wants. There's no reason for us not to treat him. I mean, there's no reason for us not to listen to what he's saying. The patient then began to fluctuate. So he then began to drop in terms of his decision making. He didn't know where he was. He didn't know who we were. He didn't understand what was going on. He was becoming aggressive. And so you reassess the patient, you redo the AMTS score, and it's dropped. Now it's about 7. So 7's not really the best, but it's not too bad, because some patients, that's their baseline. But we know this isn't his baseline because he's dropped down. The discussion is we had with his daughter again. She's still not compliant. She still wants it to be, you know, him to be full escalation. We then go back to the patient. We then redo our assessment. We then figure out, you know, what is it that's causing this patient to be so delirious. And then his AMTS continues to drop, but then it goes up again. It then drops, and then it goes up again. And that's when we place the mental capacity sticker on this man's book, say that he doesn't have mental capacity because he's unable to retain information. He's unable to explain why he's here. He's unable to make decisions by himself. And so then we made the decision that it was in his best interest to treat him, because it was fluctuating. His decision making could have been affected in his aggression by the infection that he had. Oh, I think someone has their hand raised. I don't know how.
Hi, can you hear me?
We can hear you.
Hi, I just have a quick question, because basically, if the patient doesn't have mental capacity, the doctor decide, but does the daughter have like any decision to make or something?
So that's a good question. So if the patient doesn't have mental capacity, that means that they're not able to make their own decisions, right? So then that's when we contact the next of kin, who then can help make a decision. However, ultimately in that situation, you have to think, medically speaking, what is in the patient's best interest. So even the patient's daughter was like, can you please treat him for escalation? Because he had so many comorbidities, it wasn't in his favor to be for full escalation, in the sense of that if anything was happening was, you know, his heart was to stop working, cardiac arrest wasn't the best thing for him, because he had liver cirrhosis, he had chronic alcohol, you know, abuse, he has a pacemaker fitted in. But that doesn't mean we won't treat him medically. We will still help him and we'll go against him telling us, no, I don't want to be treated, to yes, we will treat your infection and we will try and fix your pacemaker and help you, if that makes sense.
Yeah, thank you. Yeah, that makes sense.
So ultimately, in that situation, your medical opinion is most important, but you also then have to work with the daughter and not work against her, and explain to her why you are making this decision. And after we explained it to her, she understood that the benefits were outweighed by the risk ultimately. But in some situations, let's say, for example, he didn't have any comorbidities, then decision making would be done with his daughter, and yes, he would be for full escalation, and his daughter would be informed and taken into account.
Thank you very much.
No worries. So that's it. So finally, some words of wisdom. Don't panic. It's completely fine to feel like you don't know anything. It's completely fine to feel like you're out of your depth. I felt like it. Most people do when they start their job. There are loads of things that you feel like you don't know, but you do know. Read on the acronyms that they use. They use a lot of them. It's okay to ask for help. Know your point of escalation. So your reg is always going to be your point of escalation. They are the most useful and lovely people to ask for help because they're in between you and the consultant. Most consultants are approachable as well, so you should ask. It's okay if you think a question silly, because that question that you think silly might have a knock-on effect if you didn't ask. And no matter what stage you get at, I'm sure everybody feels like that. Thanks for listening. And does anyone have any questions?
Okay, guys, just before we do move on to the Q&A, I'm just going to share the link in the Q&A. You should be able to see it in the answered questions. And please do fill that in. We do love feedback over here. So knock yourself out, be a critic. I'm just going to share my screen quickly. Where is it? Here we go. Right, let me just sort this out. Okay, it'll be there in a second. Okay. Yeah, so feedback, there's a QR code over there just to make life easier. For those of you who do know how to use it, just open your camera app and just wave it at the QR code and it'll pop up on your phone. Technology, I know it's amazing. Again, a big thank you to our sponsors, Lectorio. And I do really do recommend them, not just because they're our sponsors, but they're actually a really great platform. And that's one of the reasons we sort of reached out to them, because, you know, they're great. Okay, moving on to, okay, here we go. Time answer here. So if you guys click on the Q&A, you should be able to see it in the answered questions and the feedback forms over there. Once you do fill it in, you'll get an email with your certificate for attendance and Lectorio 50% discount code that you can use. Right, yo. Okay, some of the questions. So somebody, Dr. Dhaliwal, somebody asked, are you going to be in acute medicine for the entire FY1 year, or will you be going into any other specialities later on?
So I'm in acute medicine for 6 months. I then swap over to general medicine in August. So general med could be respiratory, cardiac, and gastro. Yeah.
Great. Another anonymous attendee asked, do you get a shadowing period before you started work? If so, did you ask for it, and how long was the shadowing period?
So some trusts give you shadowing periods, some trusts don't. My trust used the thing of being supernumerary, which means that you're shadowing, but unfortunately, because of the COVID pandemic, it actually wasn't supernumerary, so we were just working straight in. But they tried to buddy us with somebody for the first week, and then after that, you were in it. But the person that you tend to be buddying with tends to be on your shift anyways, so you can ask them for help. And they're a fellow FY1 that's graduated in England that tends to be has been working in that system for a while, so they're able to help you.
Absolutely. I think the other thing that's important for people who go straight into working after they graduate is, again, like Dr. Dhaliwal said, it's important to ask for help, because you're not going to be their first IMG that's coming there and doesn't have exactly a clue of how the system works. And if you,
100%.
yeah.
It's like, sorry, but like they have other doctors out there that might not be from Europe, they might be from other international places, but they all feel the same. And even from moving from trust to trust, from talking to other doctors, even when you move to another trust, it feels alien. So it's okay to not know like where something is or how something works. So like, don't forget, you know medicine, like you've been taught that. It's just applied slightly differently to what you think. So when you figure that out, you'll be okay.
Yeah, absolutely. Another anonymous attendee asked, do we measure patients' capacity using the AMTS?
So yes, you use that in one way to help you to be able to understand if a patient has capacity, because if they have a really low AMTS, like for example, 5, you kind of know then in that situation that patient's not going to be able to understand what's going on because they didn't even remember me telling them who I am at the beginning of the consultation or knowing what year we're in. So then you just have to think to yourself, that's something that can go towards it. But also you ask them when you're talking to them, do you know what's going on? Do you know why you're here? And then you talk to them about the treatment you're going to perform. And then you're going to ask them, can you repeat back to me what we've just spoken about? Or, you know, how do you feel about, you know, if I was to do this, you know, in this treatment, how do you feel about if we were to take blood out and things like that? And you can generally get a gauge in from that. And then again, if you're not sure if someone has capacity, you are able to then go and pull someone in with you, like a fellow doctor or nurse, to then redo the assessment with you to just double check.
Yeah, absolutely. Another question asked by Satnam was, how long did it take for you to get used to your new role?
Oh, that took me, I think, I won't lie, my first day I was petrified. And I think I was petrified for a good week. And then I went through the period of phase where I felt like I didn't know anything and everybody else around me knew loads. I'd say you give yourself about a couple of months realistically to be able to find your feet, to be comfortable, to be confident in what you're doing. But after a month, you'll know, you'll be in the rhythm, you'll know where things are. Like, it's little things like not knowing where something is that can throw you off as well. But actually, when you feel confident in what you're doing, will probably take a couple of months. I'd say probably about 2 or 3.
Yeah, absolutely. I think this question is actually quite a good one. So somebody asked, is it easy to get into practicing mainstream medicine after studying medicine abroad? Did you face any discrimination upon return? And is it easy to get a job?
So I would definitely say getting NHS experience does help your situation. Showing that you've actively tried to shadow during your time as a student, that also shows that you know how the NHS works, because people that are going to hire you want to know that you know how their system works. So you having shadowing periods, work experience, placements, that shows that you've been exposed to their system, and that's important. In terms of, when you're going through your interview process, yes, they're going to look at where you've graduated from. Yes, they're going to question, okay, this person studied in, you know, an Eastern European country, but that doesn't mean that you're not any good of a doctor in comparison to somebody who studied in England. So you just need to make sure that you are calm, you answer the questions correctly, and you should be fine as long as you can, you know, expose yourself to enough NHS experience. There are certain topics that are buzz topics. So currently at the moment, the buzz topic was DVT, so deep vein thrombosis, and having pulmonary embolisms. So just find out what the hot topic is of that time, and knowing the treatment, the signs and symptoms, that will all help you through your interview process.
Absolutely. I think another big thing is when we do go back, of course, is obviously the lack of exposure, as the doctor was saying, to the system in itself, and showing a familiarity to that. It does go a long way. It really does. I think another thing I've been told quite a bit was try to understand how they process information, even if it's like clinical, in terms of they have their whole system that they've been teaching students right from first year till their junior doctors of, you know, the ways you go through clinical cases instead of just going through them. And when I got that piece of advice, it completely changed my approach personally, looking at, okay, this is how I need to look at a clinical case. This is what I need to consider. And they really do want to hear it all, even if it's obvious. and they want to have minimal interference. So like when I'm doing my essays for surgery over here, or when I'm going through my syllabus, the treatment for everything is surgery because it's surgical. But in the UK, the first line of treatment is always conservative because they're trying to avoid surgery. So it's a completely different mindset, I feel. Wouldn't you agree, Doctor?
No, I 100% agree. What in England, they're taught via flow charts, if you think about it. So it's always patient comes in with this, what, is there this, is there that? And then you follow like a little chart almost. So you need to kind of follow their thought process, like Mohsin said. So Oxford Handbook, your best friend, the clinical handbook, that is a really good one. 60s and 50s, you should read the Oxford Handbook Foundation book. That's really useful. I myself being in acute, I read the acute handbook because that's really good. And then when you start going off, or you're starting to go into different specialties, reading that handbook is useful for us in the sense that you would have gone over the basics, but you don't know their specific algorithms and flowcharts and protocols, for example. That will help you. NICE guidelines is another thing that I really would recommend going over. And just knowing like what medications you give where and when, because that's a big part of things that you'll realize that you feel like you're lacking.
Absolutely. I think somebody asked, and I'm actually curious about this one myself, what do you want to specialize in?
I don't actually know at the moment. I do really enjoy acute medicine, but who knows? I think it's just because I've been exposed to it first. But acute medicine, I would say, is probably the best of both worlds in the sense that you get to do quite a lot of practical procedures, and it sometimes gives you a bit of a rush, but you also get to deal with the medical side as well. So it's fast-paced, but it's a bit slower than A&E, but it's faster than working on the wards.
Yeah, it's a good place to be actually, because I've done a placement both in acute med and A&E, and A&E was just, I think you're so amped up while you're there. You're so on edge. Like you won't see people sitting around. You won't see people relaxing. And then acute medicine, you don't feel like, just dropping face first at the end of your shift. Whereas in A&E, I always felt like every time I finished, I was just like, I couldn't get home quick enough.
Yeah, no, it's true. You have days like that. But it's good fun. I would also say that, guys, sometimes more sinister things do happen in your shift. But just take it on the chin and, remember that the next day that's going to come, it'll be a new experience. Sometimes patients don't always pull through. It's nothing on you. Like, you guys did everything you could, because you will get into those situations, and you just got to make sure you guys are prepared for that.
Absolutely. I remember seeing my first death in A&E, and it was, I think the doctor forewarned me about it, but he's like, you will have nightmares for a week. And it turns out I did have nightmares for a week. But I think after that, you really get like, okay, you get used to the process and you start understanding it. It never gets easier, but you get a better understanding of it.
Yeah, but also, guys, learn how to certify a death as well. That's really important. So certifying a death is a patient will die, the nurse will call you, you'll be asked to go see the patient. Patient's obviously, passed away, sadly. You listen to their chest for 2 minutes straight. So you listen to their heart sounds, check for breathing, check their eyes with a little flashlight to see if their pupils are dilating or if there's anything. You test pain sensation if anything happens, and then you write down, what you did. So no heart sound present for 2 minutes, no breath sounds present for 2 minutes, no pupil reflex, no pain stimulation, nothing. And then write time of death, your name, and whatever. That's something quite basic that I think I wasn't exposed to. But yeah, that's definitely something you guys should know, how to certify death.
Absolutely.
Because you as junior doctors will be called to do that.
I think somebody asked, can you repeat the handbooks again? So Doctor, why don't you tell them what it is, and I'm going to grab my copies just to show them it.
So the Oxford Handbook, this is the yellow, let me see if I can, it's like yellow, green and red, I believe it is at the bottom. It's the Oxford Clinical Handbook, that's the one. That's really important for like years 3, 4, even 5, It's really good. I still sometimes flick through it every now and again. You then have, what have you got there? Clinical specialties. I actually personally haven't read that one, but I'm a big fan of the Oxford Handbook series. If you're in 5th year and 6th year, go for the Oxford Foundation Handbook. That's really important. It's like a red cover. And then once you start practicing, whatever department you go into, but definitely read the acute handbook, because even being on the wards, you will experience acute situations. So it might be like patients on your ward and you're in respiratory, but they start to have a heart attack. What do? ECG, troponin levels, and then check if they're already on the ACS protocol, which is acute coronary syndrome. So you want to start giving them aspirin, clopidogrel, flunitronix, things like that. It's a really good way to prepare you for being in those situations. And genuinely understanding what to do in those situations, it helps. Even if you don't feel confident, at least you have an idea of what you're doing. That will help even for when you're escalating, because then you kind of know what you're talking about with the reg or with whoever you're escalating to.
Absolutely. My brother calls these books the Old and New Testament. That's his version of it. And I kid you not, he's literally like, so he's honestly like just made these books a limb of his. And if I ask him a topic, he will literally, like, without looking at it, he will flick through the pages and he'll be like, okay, let's go over it. Yeah.
That's how you should. I have one on my phone as well as having a hard copy. So just in case, you know, when you're in doubt, just quickly flick through just to check anything. Quick lunchtime read. Really good.
Yeah, honestly, I still carry this around. I strongly recommend it, and the other books as well. Acute Medicine for sure, the Foundation Guide, and I think there's just one for every specialty now, isn't there?
Yeah, there is. I believe there's one for GP.
I've seen the neurology one, cardiology one. Pretty much every specialty has its own version. Yeah, go for it. I think somebody also asked, actually pretty much answered the question, what can people do in Bulgaria or IMGs or international medical students do to better prepare themselves? And I think this was one of the topics. Yeah.
Yeah, I definitely think going through the Oxford Handbook. Another thing is OSCE's examinations. So yeah, you guys know the basics, like how to do a cardiac exam, how to do, you know, like respiratory and abdominal. You guys will know that really well. But I recently had like a first year who came in and was like, oh, you know, I have to have a doctor sign me off or something. And I was like, okay, sure. And he was like, yeah, I'm going to perform the knee exam. And I just looked at him and I was like, a knee exam? And then like, I knew what it was because I'd read about it from reading the Oxford Handbooks. But it's one thing when you've read something and it's something different when you're like, okay, I was at med school, we never had to do that. So prepare yourselves for like the knee exams, the hand exams. Like you come in, like you'll have rheumatology patients, for example, and you'll need to be able to explain, you know, did they have any movement in their hands, flexion, extension, were the limb motions okay? And then you need to perform, you know, the elbow, the wrist examination, the knee, the ankle. It's all about knowing these things. So learn them. Even though you're not going to get tested on them at uni, you're going to get tested with them in life. So make sure you learn them on YouTube. There are great videos out there. NICE guidelines, again, guys, if you're in 5th year and 6th year, go over them. Would highly recommend it. Like make that part of your little essay plan that you put for internal.
Absolutely. I think the other thing is, especially for IMGs, recognize and focus on your strengths and know where they are, because I think that the important thing to remember, and it's kind of easy to forget for us because it's hard to notice when you're there and when you're doing it and everybody around you is doing it. But, you know, being over here and studying abroad makes you an incredibly resilient person, because you're pretty much capable of moving anywhere and adapting to any situation.
It's true, like you guys won't think about it. You guys have been put into a different country. They don't speak the same language as you guys. You're still trying to like study a really hard subject. When you come back to England and you get faced with, you know, oh, a difficult patient or a consultant's not happy with the way you write or something, it literally won't affect you. You'll just be more like, okay, that's fine. At least I have like, you know, my knowledge or whatever. You just want to make sure that your knowledge is on top and you know and you feel comfortable and confident in what you're doing, and that'll be fine. And take it on the chin. Sometimes, you might have a difficult day. It doesn't matter. The next day will be even better. Just think of it like that.
Absolutely. Another person asked, how would you find out about buzz topics?
Sorry, say that again.
How would you find out about buzz topics?
So the buzzwords are something that I kind of just come across when I was working. It's a little Simren special, the buzzwords, but I definitely think look in your Oxford Handbook, guys. There's certain words in there that are quite, they stand out, they're in bold, they're useful, but there are a couple of more you can think of, so like baseline, mental capacity, the Rockwood Fellow Score, for example, knowing your scorings. So, like the Frailty score, Chadwick's like, and the scoring for that for like, someone's at risk for atrial fibrillation. It's in the Oxford Handbook. You kind of just need to read through it and see whichever words repeat. Sorry, is how I would think about repetition.
Absolutely. I think the other two things that I really picked up was one was keep up to date with the NICE guidelines. And that's super important because every year is changing. And they have such a different approach towards things. I've seen treatment methods based on the fact that the test for the specific disease was way too expensive. So they would do other things to avoid having the test, because obviously there's an economical aspect to it at the end of the day. So some things are just not what they seem.
Oh yeah, 100%. They cost is something very important that they think about over here. So they might change a whole treatment scheme and plan just because of money and stuff.
Yeah, absolutely. The other thing is common sense. It's like, people are only going to come to you with certain things, and I think it's usually going to be very vague stuff, especially when you work in A&E. People are coming in complaining of chest pain, belly pain. They don't even call it the abdomen. I have pain in my back, I have pain in my knee, I have pain in my leg, and that's pretty much what you start with, and you have to take it from there.
100%. Like, people are going to be very vague with you, and you need to work it out in medical terms. Sometimes the vagueness can actually help you narrow it down, rather than someone who's very particular and is like, yes, I have pain right where my left hip is. And you're like, okay, you try and think really specifically, and sometimes the answer's not there because that's a referred pain. That's not where the true pain is at. So just think of things like that as well.
Yeah, absolutely. As that doctor's joke goes, patient walks in and every time he raises his arm, doctor, my arm hurts. Like, stop raising your arm.
Yeah, it's
problem solved. Honestly, like it gets so ridiculous like that. But I think some people come in, and I think the other thing to know is try and understand people for how they express pain. Everybody feels the same amount of pain. People have different expressions. So you'll get I've seen some really tough people walk in when, the condition they ended up having or the problem they ended up having, it's extreme pain normally, but they were completely okay about it. And some people are just real sensitive.
Like, we had this guy stood on a nail gun and managed to get a nail in his foot, and he presented into A&E, and so the ortho people were there, and Acute was there, and so was A&E, and we gave him some lidocaine, and we were like, do you want something stronger? And he's like, no, I'll be fine. And we're pulling this nail out of his foot, didn't even scream, nothing. That level of pain tolerance was so interesting. But yeah, guys, remember, you're going to be referring to other specialties, so learn how to request for a specialty. So some doctors are very pernickety about how you request for their specialty. They might reject you just because of how you've done it, or they'll come down and they'll be like, who sent this request? Why did you do this? Do you think this is appropriate? So if you send your request for orthopedics, make sure the x-ray is already being done. They won't come and see a patient without an x-ray being done. Make sure okay, x-ray said, or x-ray on the findings, what they were, what the patient presented with, how it happened. Someone's coming with abdominal pain, CT scan should be done. Write the findings of the CT scan and who you're requesting it to. So surgeons won't come unless a CT scan is done. Remember that. Yeah. Some trusts might be different, but things like that you just need to remember. When you're requesting for another specialty, write it to them as if you're explaining the story, and then they'll understand it better. Don't just be like, we need the surgeons, and then you just write something random. They're not gonna engage with you as effectively as if you tell them a story.
Absolutely, absolutely. And I think, hacking how to do SBAR properly and, communicating a clinical problem effectively in a stepwise process. This is the one thing I really, really love about the NHS. Everything is bullet pointed and everything is like flow charts, and it's so easy to read all these algorithms and all these things. But I think somebody is actually asking, how do you access the NICE guidelines?
So you can literally just type into Google NICE guidelines, and then, or like, for example, let's say you want to be specific to a topic, right? Let's say blood pressure, high blood pressure, NICE guidelines, it will come up. Stroke, NICE guidelines, it will come up. Literally, it's so easy to access, which you wouldn't think it would be, but it is. BNF is another thing that's really important. I think you guys should make sure you know some dosages, if not all, but like just knowing some is really useful.
Absolutely. I think in this situation, having the internet as your go-to is better than using the books consistently, because I've been corrected because I thought, the treatment method was one thing and somebody's like, oh no, they updated that last year. I'm like, what are you talking about? Yeah.
You've been outdated, it's not even your fault.
Yeah, honestly. So I pull my book out, I'm like, no, it's right here. And they're like, yeah, that's 3 years old. So
and also each has its own guidelines, guys. So just keep that in your mind, that NICE guidelines is a general guideline for like UK, but each individual trust will then have its own guidelines. So some trusts might say, oh, if somebody's got really high potassium, you start treating at 6, or somebody might say, oh no, you start treating at 6.2. So just make sure you check out your guidelines if in doubt, because they're there to help you as well. So there's always information available everywhere. Even when you feel like you're panicked and you're stressed, just remain calm, think basics. It's all there.
Yeah,
Because
absolutely.
that's how it's set up when you can't escalate. That's what you got to think. There's sometimes there'll be situations where the person you're escalating to is busy with another escalation. There's still resources out there to help you, calm the situation down until that escalation point is available.
Absolutely. And I think that's another funny thing that I quite recently discovered, is that every single trust has their own guidelines, which is extremely frustrating because some of them are widely different, but I think most of them are okay. Most of them have massive overlap, but some of them, you do see quite a bit of variation, don't you? Sometimes.
Yeah, 100%. And sometimes it can throw you off, but as long as you know the NICE guidelines, that's okay, because then you have a leg to stand on. But then always just double check with your own trust. But while you guys are studying, NICE guidelines all the way.
Yeah, absolutely. Somebody asked, what clinical question did you get for your interview?
So I got the PE, pulmonary embolism. So
Yes.
one of my questions was a patient has had post-operative hip replacement. They've been in hospital for 5 days. They start to desaturate, which the cause could be. So pulmonary embolism is a big hot topic at the moment. And I think it might be as well for the next year to come. And I think it will be more based off of the vaccines as well. So think about low platelet count as well. That could be another thing. It's quite easy for you guys to check what's hot on topic. Check online to see what's going on. Normally that should give you a rough idea. Falls, a couple of people had falls that I know about. I think somebody had exacerbation of COPD. So those were a couple of comments.
And again, these are super, super common topics. They just look at the demographic in terms of like, okay, what are people going to be coming in with a lot? And if you can sort of handle that, they can rely on you to do most of the work properly. And I think that's just a very good indicator for them if you hack that clinical scenario they put in front of you.
Yeah, 100%.
So somebody asked, actually, this is quite an interesting one. How much did you need to know about clinical governance for your interview?
Clinical governance?
Yeah, not a lot.
So,
not a lot from our part.
Yeah, you wouldn't really need to know a lot. I think just like you need to read around, make sure you know their basics.
Yeah.
But you don't need to, you're not expected to know a lot because they know you've just literally graduated, you're fresh. You're literally no different to one of their graduates in some respect. So they didn't expect too much from you.
Yeah. And I think funny thing is if you guys talk to UK graduates who studied in UK medical school, they're just as scared, they're just as unprepared, they're just as worried, they're just as likely to mess up and slip up. And that caught me off guard because I was just like, oh, okay, so the problem isn't with IMGs, the problem's just with medics graduating.
Yeah, like honestly, like I remember like the first week when I started working, I'd go home worrying about my patients because I was like, did I do something right? Did I put blood forms out? Oh my God, did I put the medication in? What if the patient gets the wrong meds? And literally it kept me up all night for like a good couple of like days. And then I realized that that's more like everybody goes through that. Like I once had a reg ring me, on his way home, and he was like, Simren, can you please check on something? And I was like, yeah, sure. Because even that, at that stage, there's still like, you're still worried because you are treating somebody's loved one. So it's okay to feel scared. But yeah, it's completely normal. Like they all felt like that, even the UK graduates. Like speaking to the ones that I worked with, they were just as scared as we were. And think about it, they were exposed to the system already. So it's normal.
Absolutely. And I think this comes back to the point the doctor Dr. Dhaliwal was discussing in terms of asking for help. Because this is the thing, everybody's been through it and everybody knows what it's like. So when you ask for help, it's not like they're going to turn around and say, like, I wasn't struggling. So they all were, everyone was.
The worst you'll ever have is like somebody will make a comment. Oh well, whatever. Like take it on the chin. As long as someone answers your question, that's fine. Like it'll be okay.
Yeah, and this is what I'm saying about people IMGs being incredibly resilient because we get that we've been in like hospital situations where we get an answer wrong and we get a comment thrown at us. So I think like we're used to the criticism, and I think that's really, really good because for me personally at least that evaluates my ability to grow in any situation. Really is how much criticism I'm willing to take in that situation, because that's it. Like you can push as much as you want, then you could keep asking questions. The worst they're going to say is no to you. It's not like they're going to lock you up and throw you in prison for asking a question. Yeah,
exactly. And like somebody will help you, like even if you think that person's a bit scary or whatever, there's always multiple people you can escalate to. And even if there is a fellow junior, will be able, sometimes they'll know the answer because they've dealt with a similar situation already and they've just learned from it. So you can always ask one of them. That's a good point. And it is fun as well, guys. Like you will enjoy it. So it's not all bad.
Yeah, you'll get to see some really interesting stuff as well. I feel like that's the only thing where when you're working in emergency of any sort, you could expect to see something different for sure. Whereas in other wards, maybe not so much, but in emergency for sure, you will, if you spend enough time over there, you will see something that will completely blow your mind.
100%. Like I work in acute, but a couple of times I've been shifted to a ward when like we didn't have enough doctors on a particular ward, and like working on acute is so exciting because like in your day you will see an MI, you'll see exacerbated COPD, you might see somebody with ascites and you have to do a tap or something, and then you'll be on something like stroke where everyone's got stroke and everyone's just got a presenting symptom, or somebody's going through something. Or I've worked on respiratory and you'll just be like, most patients got asthma or exacerbated COPD or lung cancer or something. But on acute, you'll see so many different things and so many different ages as well. It's really fun. And it's a good place to learn, like Wilson said, because you get exposed to enough practical procedures. Because you want to make sure, one piece of advice to give you guys is be confident in your practical procedures before, because you're going to start your job and you're going to feel panicked regardless. But you're going to feel more panicked about practical procedures. Get the 15 core procedures down and then panic about if you're medically adequate or not, because if you can take blood by yourself, you can catheterize a patient, you can take an ABG, you can do a peak flow and, know how to read an ECG or understand the basics of even how to perform an ECG, that will instantly just give you a bit more of a confidence boost because you know how to do some things. But don't stress too much then being like, oh my God, I don't know anything. If you can do the practical bits, you're kind of there. And then you can work on, knowing you're building on your medical knowledge and things like that. Because doing practical stuff will be part of your daily day jobs as being an FY1 or 2 doctor. You know, you'll be expected to catheterize, take blood, change this, change that. So feel comfortable in it.
Absolutely. And I think this is the thing is like, when you're a junior doctor, you're technically still in your education. You're just getting paid for it instead now. But you're still learning, and they definitely like expect you to be learning on the job and make mistakes as one does. Nobody gets 100% on a test, so you can't expect yourself or anyone around you to operate, you know, with 100% success rate of everything they do or know it all. So I think just treat it in the same sort of mentality where you're walking in, and you're still technically in uni. It's just the location has changed, the task has changed, and you're just focusing on the practical aspects now. And that's how I look at it anyways.
Yeah. That's a good way of looking at it. It's true. Like, you're still learning. Like, that's your point to learn now.
Yeah, absolutely. Okay, I think we've pretty much gotten through all the questions. I think we missed some of them, unfortunately, but I do want to thank everyone for being here, and I definitely want to thank Dr. Dhaliwal for being here. Amazing webinar, amazing lecture. Thank you so much. I'll leave this call on for about another couple of minutes. If you guys still want to access the feedback form, it's in the Q&A. You should be able to see it in answered questions. So it's over there. Just give that a click. It won't take you more than 2 minutes. And yeah, thank you again, Dr. Dhaliwal.
No worries, it was a pleasure.
Amazing, great. We'll probably have our next one in some point in July. So I'm really looking forward to having you guys there for then. Again, thank you. Good luck with your exam sessions. Take care and stay safe. Keep wearing your masks. Keep using hand sanitizers. Yeah, have a ball. Okay, take care.